Our disability is our greatest strength. It gives us the supervision to see the issues facing humanity from a more inclusive perspective and the grit to fight back against all odds. Welcome to Super Adaptables, the More Than Walking video podcast discussion. Welcome to Super Adaptables, the podcast where people of all abilities gather to discuss pressing issues that affect the disability community and their implications for the world at large. We're your host. I am Corey Pheez, C4 complete quadriplegic since 2005.
And I am Jonathan Sigworth, C7 complete quadriplegic since 2006, both of us hailing from the great state of Connecticut.
Yes, sir. We are recording this on Thursday, the 20th of March, 2025, first day of spring, even though I know for our friends in the Midwest, it does not feel that way.
How's that blizzard, Heather?
We're digging out. We're digging out here in southeast Nebraska. I've grew up here my entire life, and I've never seen one like this. So we're digging out.
I'll be happy to go outside and enjoy some of our finally warm weather today and be thinking of you, Heather.
I appreciate that, Joe.
Indeed. So in a little bit, we'll be discussing Medicaid, keeping the vulnerable safe, covered, and informed.
And before we do, I just want to remind everyone that Super Adaptables is made possible in part this year by a grant from the Christopher and Dana Reeve Foundation's National Paralysis Resource Center. The information provided and opinions expressed in these podcasts do not necessarily reflect the views of the Christopher and Dana Reeve Foundation. For more information about the Foundation's National Paralysis Resource Center, visit christopherreeve.org. Also, I should note that the views expressed on this podcast do not necessarily reflect those of More Than Walking either, but belong to us as individual speakers. With that, we would like to welcome back two of our previous guests, Heather Miller, who's joining us from Nebraska, as we already mentioned. And Heather is a certified benefits counselor at Spinal Pedia, which More Than Walking works with to provide peer mentoring support, employment mentoring, helping navigate the system to newly injured and their families. So welcome, Heather.
Thank you. Glad to be here.
Also, we would like to introduce Joe Short, an independent living advocate working for Independence Northwest. More Than Walking is working with their organization to get the word out here in CT about social safety nets and what changes can be made so that the current and future generations can continue to benefit from these programs. And we hope that these discussions will serve as an example to those of you viewing out there. So thank you both for being here.
Thank you, guys.
Thanks.
So previously, we had the opportunity to talk to a few of our super adaptables about their experiences with Medicaid. How is it managed in their particular state, whether by privatized MCOs or managed care organizations, or by the state itself? And perhaps the most important question is, what are our local, state, and national leaders saying about these issues in particular? And as we seek to have a more surgical discussion about this topic, we want to remind our viewers about some of the benefits Medicaid offers. So Medicaid offers a treasure trove of benefits such as transportation to medical care, in and outpatient, hospital services, rural health clinic services, federally qualified health center services, early and periodic screening, diagnostic treatment, laboratory and x-ray services, nursing facility services, family planning services, physician services, home health services, nurse midwife services, smoking cessation, counseling for pregnant women, certified pediatric and family nurse practitioner services, medication assisted treatment, freestanding birth center services, routine patient costs for clinical and child beneficiaries. And the list can go on. And the most important part is the fact that these things are and could be in jeopardy. As we discuss this topic today, we want to get a more detailed explanation about what Medicaid means for all of us here in the U.S.
Corey, a really important one that is left out of that list is durable medical equipment.
Yes.
Wheelchairs, those $5,000-$10,000 manual lightweight chairs, and those $40,000 to $60,000 power chairs.
Mm-hmm.
So that's really important. And also the home health, as you mentioned, like the long-term caregiving support. It's the only insurance company that covers that long-term, other than some long-term health insurance. So these are great points. And the conversation we had last week brought up issues that left me unsure if the public and lawmakers understand the depth, the depth of what decreasing funding would mean to disabled Americans, like the extent to which that would really affect us. For example, one of our guests brought up that the money she receives for disability is quickly spent, leaving barely enough funds to purchase her undergarments like Depends or creams meant to reduce the risk of bed sores. And currently in her state of Texas, Medicaid does not cover those types of care products for women. Whereas it sounded like previously they did, or in another state where she lived before it did. Another guest spoke about accidentally forgetting to re-enroll back into the system and how it took months and how difficult it was to reapply, with the same credentials that she always had, but just to get covered again.
And I'd like to speak about that a little bit, Jonathan. I have consumers that contact our agency quite frequently who don't qualify for Medicaid, and they're only on Medicare, and Medicare doesn't cover any incontinence supplies of any sort. And so Medicaid covering those incontinence supplies, the money that it saves just not in having bed sores or UTIs and everything of that nature, it's amazing that other insurances don't cover something as simple as incontinence supplies. I've got one woman who had bladder cancer. She has no bladder, and insurance won't cover anything. And because she's not eligible for Medicaid, because the income guidelines are so low that you can't get something as simple as that should be. Everybody should have that.
Absolutely. I mean, in rehab, one of the first things they tell you to prevent bed sores is, make sure you clean up after an accident, whether it's bowel or bladder. And the fact that, if you don't have the funds to pay for these things out of pocket, and it's a regular, it's a regular need, it's a regular cost that you need to dish out, like that's going to affect your health.
Oh yeah.
Entirely preventable ways. It makes it clear that these are not like medical professionals sitting down and saying, okay, what are the essential things that Americans need to stay healthy? These are people who have no idea what health even means. They're just looking, okay, what's a budget item that, what's an item on this list that we can cut out and make our margins look a little better? What are the cost savings that we can find? So it took 3 months, for this one person to re-enroll, and during that time, countless others also find themselves in similar situations. But on Tuesday, this week in Connecticut, 400 people gathered in protest at the Capitol regarding the recent budget passed by the U.S. federal government and its potential impact on Medicaid. This protest was known as the Medicaid Day of Action. And Joe, you weren't just down at the rally, you had the opportunity to speak to the crowd alongside our local and national leaders. So before we get to our questions, can you tell us about that experience? And, when you had the microphone, what did you say? What was your message to fellow people with disabilities?
My message. Well, I'll tell you, there was a lot of pressure there. I mean, when you're speaking alongside the governor and senators and people that are talking, used to crowds like that, it's a little bit of a difference. But nonetheless, my message was my lived experience with being on Medicaid. I'm on Medicaid for working disabled, and that allows me to remain in the community with the supports I need. And it's one of the only, like you had said, it's the only insurance that provides the in-home supports. It doesn't matter if public or private. And so I talked a little bit about my lived experience, and then working at one of the independent living centers, advocating for individuals with disabilities and what it means for a lot of the consumers that I work with, and just bring like that. And it was nice. We had a lot of mixture. There was a lot of individuals. It was good to see a lot of individuals with disabilities in the crowd. A lot of politicians and a lot of elderly, because it's going to be affecting them as well. And I think the data was 42% of people over 65 are on Medicaid, and so that's a huge population.
I heard that over 24% of Americans are relying on Medicaid, and it's not just people with disabilities. It's also working families who don't make enough to make ends meet, and this is the only insurance that they can really access. Do you feel like you were heard, or that the speakers were heard, or um, that things were covered well to really get the message and the priorities across to people who heard about the rally afterwards?
Honestly, no. I think that it's the the reality is it's such a huge issue, and the I mean it's not being covered. I mean we're looking at giving an $880 million tax break to the top 0.001% in order to be able to take these benefits away from millions of people. And it should be on the front page of every news, and it's not. I mean, the 400 people, that's a drop in the bucket compared to the millions that it's going to affect if this happens. This isn't just like you said, it's not just us where it's going to affect someone with a disability. It's going to affect, you know, one out of every five people, and that's a huge number. And I, I'm I'm not a Democrat. I'm not a Republican because I can't follow either one of them, to be honest with you. But I wouldn't trust Trump's words as far as I could throw them, and it's just leaving it in the hands of politicians to be able to juggle whether or not. I mean, these cuts are going to affect nursing homes. These effects they're going to cut the in-home supports. So okay, you don't have in-home supports now. Now you have limited availability of where you're going to go for a nursing home. Uh, what happens to you? What's next?
Yeah.
And the reality of it, it's too scary to face.
Yeah, and I think you're hitting the nail on the head because it's leaving us all in like this kind of suspended animation because we don't know exactly where it's going to go, and the effect goes beyond people with disabilities, goes to low income families, it goes to um, parents who have children with special needs, which speaks to funding, and that's something Heather, you could tell our viewers and add, how is Medicaid exactly funded?
That's a great question, Corey. It's funded by both federal and state governments. Federal pays a portion, state pays a portion. To dig deeper further into that is outside of my wheelhouse. But it is funded both on the state and federal level. So we don't just have to worry about these folks out in DC. We got to advocate in our own states as well. And that's one thing I've seen. I've had the privilege of working with individuals with disabilities who are going back to work for over a decade now. The last 6 years of which my clients mainly had spinal cord injuries or illnesses. And this is life or death. I had a gentleman who went 4 months reusing the same catheter because he couldn't get his Medicaid renewed because it was, we'll get to it when we get to it. And he could not afford to pay them with the Medicare reimbursement. They were unaffordable. I had a lady in another state. It took us 8 months of back and forth to get her Medicaid buy-in program reinstated. Fortunately, her medical supply company essentially gifted her catheters and different supplies while she was waiting the 8 months. I have another one who her employer paid for her catheters because she's in limbo on dealing with Social Security and Medicaid in her state. I have met some amazing workers at both the state and federal level, but there is a genuine problem when it comes to turnaround time and not understanding the importance of what that Medicaid eligibility means for some people.
I'd just like to interrupt there for a second because Heather, you reminded me of something. Back when I was first paralyzed, I've been paralyzed since 2002. And when I was first paralyzed, my insurance allowed me four catheters per month.
Oh,
They realized eventually that providing us with the proper medical equipment proper equipment, clean equipment, sterile equipment, reduced money because we weren't in the hospitals all the time for UTIs. We weren't having issues, and by providing us with the right equipment, it saved the state money. So, uh,
It's a valid point. Yep. I unfortunately, my client that was 4 months without, he suffered multiple UTIs, hospital stays that probably cost 100 times more than the supplies he needed.
absolutely.
Not to
I mean,
mention within that, sorry, John, not to cut you off. Not to mention within that hospital stay, it's not just like, okay, it's a quick treatment. It's
No.
like literally IV antibiotics, and you're there days, more likely, than not, it'll probably take a week for it to all cycle. And then you may have to go home on oral antibiotics as well, just to clean your system out. But John, what were you going to say?
oh yeah, I was just gonna throw in more examples like the fact that uh, if you use an indwelling catheter, there's insane limits. Like you can only have one Foley catheter a month, and what happens if that one gets damaged or drops on the floor or something like that, or if you need to travel, you want to have backup equipment if your bag gets lost or something like that. There's so many different restrictions on just day-to-day life, being able to just live and move around and travel or do anything because of the extreme existing limits to Medicaid as it is currently funded, right? So while we're talking about Medicaid, we're talking about these threats of cuts, but we're also talking about how it really needs to be expanded. Like the idea that cutting any part of this program would help improve outcomes or help improve the quality of people's lives is just kind of separated from reality, as we've been discussing. But wanted to get Heather and Joe's take. Kind of skipping ahead a little bit, but when we're talking about these federal funding cuts, can you explain what forms that would take and kind of the trickle down effect of that just a little bit?
The trickle down effect. I mean, I'll start on the first one there of stricter eligibility requirements. The eligibility requirements right now are really, really low. Um, there's Medicaid A, B, C, and D, and so Medicaid C is what I know the best, and that's for age blind and disabled, and the income limits for Medicaid C haven't been increased in 50 years. So you're going back to income limits that are severely behind. You have to be practically in poverty in order to be able to even be eligible for it to begin with. And the asset limit was $1,600. And so if you're talking even stricter eligibility requirements, that right there is, I mean, nobody, and the only way to get into it if you don't meet those is with a spend down. And a spend down means you have to spend any money that's over the income limit on medical related systems. So I've got consumers that are only making, say, $1,400 a month, and they've got a $3,000 spend down every quarter. How is that possible? And if they make even stricter eligibility requirements, these people aren't going to be able to eat. They're not going to be able to pay rent. They're not going to be able to, afford anything except for out-of-pocket medical expenses to be able to meet basic, health requirements. So that's one. We already talked a little bit about the benefit reductions. I mean, what that's going to cost, and but is it going to mean that we're not going to be covered for wheelchairs? We're not going to be covered for incontinence supplies. You name it. We don't know what they're going to reduce. We do know that they'll probably reduce the reimbursement rate, and you're going to have a harder time finding doctors that are going to accept it.
Well, and I know that when we're talking about federal budget cuts, they're not actually going into every single state and saying this is how you have to change Medicaid, right? They're shrinking the amount that they're providing for that shared that cost sharing. They're just providing less, and so the states have to pick up the tab. Or if they can't afford to pick up the tab, then they have to, as you said, do other things like make eligibility requirements more strict, or reduce the benefits, or reduce reimbursement rates, or close centers that are in rural areas that maybe see less traffic. Heather, do you have anything to add on kind of the mechanisms by which the cuts would kind of be realized, and
Yeah,
any other
and you're
impact?
right about the states having to decide, how they're going to rework their budget based on federal dollars. I I'm starting to see in my work a lot more providers not taking Medicaid because of the low reimbursement rate, and people are not able to see the doctors they want or the ones they've been using because of those reimbursement rates. Other than that, it just, if we're cutting more and more, that means where's the staff that are going to process these applications? Are the wait times going to be pushed out even longer than they already are? I also, in my work, a lot of times someone's Medicaid eligibility depends on the actions done at the Social Security office. And right now, things are so far behind in those offices. Just as one example, I have a gentleman who should very easily qualify for a Medicaid buy-in program well below the income limit, except for we cannot get his Social Security disability insurance check stopped because they're 330 days out on work reviews. That Social Security check that he's being paid, he's not due, but it's making him ineligible for Medicaid. So it's not just the state, we've also got to rely on other agencies to perform functions so that the state exchange can say, oh, yep, I can't just tell a state Medicaid worker, they're not really due that benefit. It's an overpayment. They're going to have to pay it back. It doesn't work that way.
And
And I can
these
think of several
agencies.
examples like that.
Wow. And these programs aren't even talking to each other in this
No.
situation. It's all the communication, the filling in the gaps, it's all on the shoulders of the person with the disability who's going through the crisis.
And if someone is being very, making good decisions, saving their SSDI checks, knowing they're going to have to pay them back, and boom, we're over the resource limit for Medicaid now.
Wow. You brought up a good point in terms of, over the past, I would say, you know, 10, 15 years, you hear politicians typically say, you don't want the government in your business and choosing your doctors. But if you decrease the funding, guess what? Like you just said, doctors are saying no, like the reimbursement rates are too low, and therefore, like, I'm not going to take it. So now you don't have the option to choose
Right.
that particular doctor or even possibly the clinic that you want. And then Joe brought up a good point about just the trickle down effect. I think about when we talk about wheelchair repair here in Connecticut and some of the industry leaders, that they want individuals to go to their shop in order to get their repairs made. Well, if that person depends on transportation that's in part funded by Medicaid, you're back in the same conundrum, right? But moving on a little bit, who manages it in terms of Medicaid, and what are some of the pros and cons of private MCO management?
I can tell you there are managed care organizations, or MCOs, that kind of oversee that Medicaid and how it's spent and where it's spent. And then there are some Medicaid categories in states that are not MCOs. And for example, in the state of Maryland, their Medicaid buy-in program is not a managed care organization, which for someone in Maryland who qualifies for REM service, rare and expensive medical, because they're not in an MCO, they can't keep those services. So if they have to go to that Medicaid buy-in from a traditional Medicaid, they're losing skilled nursing care. They're losing numerous hours of personal care assistance, all because of the way a regulation is written. So the MCOs, I'm not an expert on that. I just know that being labeled MCOs versus not in some of these Medicaid eligibility categories can have giant ripple effects on the people that utilize them.
It sounds like it's especially complicated if you're in a state that uses both and
Correct.
you have to switch between both. So, Joe, maybe you can speak to this, but I know that in Connecticut, we have not had a MCO model. We've been one of the few states that for the last decade or so has resisted it, but there is some interest in uh, reverting to managed MCOs or managed care for long term health services. When Medicare is managed well by a state, um, as a part differing from an MCO, you're using a public entity, you're using the government, which has transparency, it has different mechanisms, it doesn't have the same profit motive as a private company would. What you do see with MCOs is, as I've said many times on this podcast, uh, they are paid the same amount, the fixed amount per Medicaid beneficiary that they cover. So if you have 100 patients who they're managing, they're getting reimbursed the same amount per person, and all of a sudden you have one of those individuals who has to go to a nursing home after a spinal cord injury because their home isn't accessible yet, and then they need a $60,000 power chair at the same time. Why would you want to dish out $60,000 for a power chair if you're already paying for their nursing home care? There's no incentive to do that, even though it's in the best interest of the patient. And so we've seen individuals in New Jersey and other states who've spent years without access to a power chair, which they have a legal right to under federal law. But because they've been managed by MCOs and there's not enough state oversight or regulatory oversight, these things happen because there is a financial incentive for these things to happen the way they do. So that's just one of the risks of MCOs that we've witnessed, that wanted to highlight. So, but on the same token, maybe there's some more efficiency, but efficiency at what cost, in what terms?
I honestly think the biggest thing, and this is because of the primary disability population I work with, is the personal care assistance, and fighting for hours. I had a state say to a client, we don't do 24-hour care. And I say, yes, you do, because I have another client that gets it, that gets 24-hour care. So the personal care assistance is huge. And the way I look at it is that individual has to have that care and those supplies and that service to live or work. So we either change the laws so they can work, earn money, contribute to the economy, live a good life, have better mental health, and cover those services, or we force them to sit at home and not work and manipulate their wages so they can get those services. When they're life and death services, they're going to get them one way or the other. Why can't we let someone just work to their fullest potential and still pay for those services when we're going to be paying for them anyway if they don't work?
Yeah. There's two programs that I think are the most important, for individuals with disabilities, and that's the Community First Choice program and the Money Follows the Person program. And the Money Follows the Person program is a Medicaid funded program that transitions people out of nursing homes back into the community so they can lead a normal life, or as normal as possible life. They're not stuck in an institution for the rest of their lives. And there's people that we transition out that have been in nursing homes for 6, 8, 10 years that didn't have access to the supports that they needed. And just because you get a spinal cord injury, or because some of these folks are young, and they don't have an accessible home to go home to, or the supports that they need. And how would you like to be 16, 18 years old, living in a nursing home with no thought of being able to get out? And the other program, like I said, is Community First Choice program, another Medicaid funded program under the Affordable Care Act, that it's to provide supports for individuals that are already living in the community that can't get the services that they need. There's a lot of waiver programs, and there's minimal slots for those waivers. So being able to get on a Community First Choice program and it actually increases your income limits for Medicaid, and so you're not under as strict guidelines, but it allows you to have the supports that you can get back into the community and be able to work and lead a productive life, like Heather had said. And without these programs, I mean, people are going to be without the supports they need.
You know, it makes me wonder, like, what exactly are they assessing as far as risk is concerned? Is it better to keep someone institutionalized or inside of a nursing home and paying a particular fee than to get them into the community, into an accessible home, or pay for those modifications if they have an existing home already? Like, what is really the cost differential between the two? Um, and then, speaking a little bit to what you said about one of the politicians who kind of rebuffed the need for Medicaid and try to pivot that, we're giving money to people who are able to go to work. And it's not necessarily that people aren't out there working. What it is that people just don't have the income and the wages that is high enough to maintain not only paying the everyday bills, mortgage, rent, utilities, but also having good healthcare coverage, which also ultimately leads to like preventative maintenance so that they don't wind up in a nursing home and having to shell out thousands of dollars.
Yeah. I mean, and hearing you guys talk about this, I'm also realizing that what makes Medicaid unique is it's the only insurance program that is really like we decide what it covers, like at a state by state level. Like it's voters, like it's us, it's the people we elect who can go and change the policies. Like, are we going to have an income limit? Are we going to have an asset limit? Yes or no? If yes, what is it? What is the state Medicaid program going to cover? Like I'm sure there are in the depths and weeds of all of this, there are some federal regulations probably that say it can cover this, can't cover that, but there's a lot of flexibility at the state level for what it can, because Heather, I don't think it, like, there are some states, right, that don't allow their state Medicaid to cover 24/7 care, or like the hours that they need to. But like all of those things can change. Whereas like a private insurance company, like unless you're a board member, unless you're an investor, like you have no agency. But with Medicaid, we actually have agency to change what it covers and to make improvements.
Another thing, and I'm sorry if anyone asks me a question, our power is going in and out as we unthaw and undig from this massive amount of snow. So I had no volume. But here's another thing that kind of troubles me. A lot of your standard age-blind disabled Medicaid budgets are based off federal poverty level earnings. And those are the same across the country. I think except for probably Alaska and Hawaii are a little higher. But I live in Nebraska. $2,000 a month means a lot more, I'm guessing, than Jonathan up in Connecticut or someone in the DC area. And so I think something needs to be taken into account for that as well. That, my annual property taxes are probably 1 month rent on the East Coast in a larger city. And so it just doesn't seem productive to have that blanket over the entire US when you've got substantially different costs of living from state to state. So I just wanted to add that in there.
No, you're absolutely right. What you spend in Nebraska is definitely different what, you spend here in Connecticut, and $2,000, sometimes just doesn't cut it. It's like a family for grocery bill per month, like literally. But we wanted to kind of move on and ask about Medicaid buy-in programs, income and asset limit requirements. Like, what is all that about for a person who's a Medicaid recipient or looking to get themselves involved into Medicaid?
You want me to take this one?
Sure, yeah.
Medicaid buy-in programs vary from state to state. Almost all 50 states have them right now. The state of Florida does not. The state of Alabama does not. I don't know if there's any others. Tennessee it's going through legislature right now to become a Medicaid buy-in program in that state. DC does not have a Medicaid buy-in. I think those are the only three right now. There might be more. But from state to state, what we find, because I work with people across the country, is that there are different asset limits, there's different income limits, and there's different ways that state agencies count income. Some agencies may count a little less than half of your income. So instead of gross, you're dealing with countable income. Some states don't. Some states, if you qualify for Medicaid automatically in that buy-in category and you're in Medicare, they're going to pay your Part B premium. Some states don't. So it's getting into those. And of course, this is not something that's readily available on a public website. I do a lot of digging into actual state regulations and policy to find out what these exemptions are. You know, there might be more difficult initial eligibility for a Medicaid buy-in versus ongoing eligibility. Example, state of Maryland, there's an initial $10,000 resource limit at application for the Medicaid buy-in. After you're in, there is no limit. Virginia's the same way. I'm sure there's other states as well. But when I'm meeting with people and I'm literally counseling them on what states are not good for them to move to because of their medical needs, that's a problem. That's a
out of
problem.
control. So that's out of control.
And without family support or anything like that, what are you going to do?
Yeah. We had a guest like that. You know, she was getting treatment, like as far as dialysis is concerned. And John, you correct me, you know, where I'm wrong, but then she had to move to like another state.
Yes.
And it's like things change once you just all you got to do is go across state lines. That frustrates me because it keeps you locked in and you can't move. Whereas it's the same thing with these income and asset limits. I guess, you know, when they're regulating it, and Joe, maybe you can allude to it, they suppose that you have enough money that you should be able to afford, you know, your care. And the truth of the matter is, no matter how much money that you keep in reserve, it's reserved because something could happen down the line, right? Like you don't worry about collecting Social Security benefits at 22. You know what I mean? You're paying into the system so that when you're older, you know that, okay, I'm going to make less money and I have built up this amount of money so that it can take care of me and my family, you know, should something happen. And I just don't like that it's regulated, you know, to some degree kind of harsh. I know in Connecticut we have the Medicaid buy-in program called Med Connect, and to qualify, you must be working to have an income of up to $75,000 per year with accountable asset limited to $10,000 for an individual and $15,000 for a couple. But Joe, I didn't know if you wanted to add in anything you've experienced with some of your clients.
Yeah, no, I mean, the Med Connect program is great. It's Medicaid for working disabled, and it allows people to actually, you know, work and have income. It's you know, it's still sad that it only goes up to 15,000 for a couple because it limits people from actually being able to get married, or the fear of if I do get married, am I going to lose my benefits?
Mm-hmm.
And so it's almost like, okay, you're disabled, you're not allowed to be married like anybody else or lead a normal relationship because you're worried about your medical over a relationship. But on the same token, it is a step in the right direction where it's showing that, okay, if you do have a disability and you do want to work or you are working, we'll increase those income limits. And so it is an incentive, and there's individuals that I know that are working part-time, or there's individuals that I know that are working full-time, and you pay a percentage. It's not 100% free. Yeah, it says you can make up to 75,000 a year, but you're still paying a percentage over the federal poverty limit on what your monthly premium is. So.
That's another good point, Joe. Some states Medicaid buy-ins charge premiums, some don't. Some are on a sliding scale, some aren't. And then the other thing that I have to unwind too is, do you use gross or countable income to figure out what that premium is? And there's so many faucets to all of this. in every state that I'm not surprised when I call a state Medicaid agency and they've never even heard of the Medicaid buy-in because so few people are qualified for it that some workers just never see it, never experience it.
Yeah,
That's an issue I've run into quite frequently.
I know here in Connecticut, it's, your first $65 of earned income is a disregard, and then they count half of the remainder of that. And
Yep.
so yeah, it gets a little bit tricky on what's earned income, what's not earned income, so.
So Joe, what you're saying is in Connecticut, that 75,000 per year, really it's twice that
Yeah, because
you could be making because that's
Is it
the
75 in countable wages?
yeah, say you're making 20,000 a year on Social Security disability. So then you would have another 55,000 a year to make before you make up to the 75,000. In reality, it would be 110,000 that you would be able to make before you hit that 75,000.
Right. So I think part of the effect of that, where they only count half of the income, is people think that they're already over the income limit so they don't even apply. When actually, if they just have their income, then that's what's counted. Then they would be eligible. And just to put this into some context, I'm not on Medicaid. I think I was on Medicaid buy-in. I think very very briefly when I was first married, but one of the reasons why my concern is I'm on my wife's health insurance through work, but I'm trying to figure out now how to get on Medicaid because I'm a wheelchair user. I've been injured for 19 years now. I know that what happens if I break my arm, if all of a sudden I need that 24/7 caregiving support and I don't have it. I have savings. How am I going to transition into Medicaid at that point in order to access that care? And Heather, you know this, like it leads people to force themselves into poverty, or even in some cases to get strategically divorced in order to qualify. And it's a really terrible situation.
Yes, our founder of Spinalpedia, Josh Basil, he talks about a lot of times, unfortunately, with clients about being happily divorced.
Yep. Yeah.
And getting all assets out of that injured person's name. And so that's why when he's talking to people about getting legislation changed, he says this is a jobs and marriage bill. It's a jobs and marriage bill that needs to go through because you're penalizing people for being married. You're penalizing people for owning assets. And whereas they could get divorced and it's fine and nothing else changes except for the paper.
And penalizing people for wanting to move between states,
Yes.
as you said, like if you're living in Maryland, it's great, and your spouse gets a job somewhere else, like you can't go because if that state doesn't have the same,
Right.
benefits that yours does.
Or you're on vacation in California and your Connecticut Medicaid isn't accepted in California. We've got state to state that they don't have to take another state's Medicaid.
And you can't apply until you're living in that state. So
and you're not a resident, right, Joe?
Yeah.
So that that you can transition smoothly, you have to wait until you're a resident before you could even start the process. So
I want to skip to the very end now because we just have a couple minutes, and I know Heather, you have to go soon. But there's talk about these cuts. It's fraud, it's abuse, it's trying to make things more efficient. Joe and Heather, real quick, what have you guys seen in terms of that? And just in terms of like making things work better, what are the best ways for addressing either those issues or to make Medicaid work better for everyone? What would you suggest?
Well, I think quite frankly, at the end of the day, you're going to have fraud and abuse, period. As much as we can crack down on that, great, but it's going to be there. We know people are going to do the wrong thing. What I experience from my standpoint, from my perspective, working with individuals trying to get qualified, is the time it takes. It's the backlog. And if there's going to be cuts, we know there's going to be cuts to staff. So is it a staffing issue? Is it a training issue? What is it? I can tell you in the state of Nebraska, years ago, we had a new HHS Health and Human Services director come in who decided to reinterpret some of the regulations. And it kicked off a bunch of childhood disability beneficiaries that were receiving SSI, or that were receiving Medicaid because they were former SSI. So you've got all these things to consider: fraud, waste, abuse, training, lack of staff, rule interpretation. And I don't know how you tackle that. I don't know how you tackle that.
Yeah, and I can follow up with that. I mean, a lot of with a lot of the consumers that I work with that are getting kicked off of Medicaid or having to do paybacks, anything like that. A lot of it is, like you said, misinterpretation of what the rules are, the laws are. They go back to work and they get a Christmas bonus or something of that nature, and next thing you know, they're getting kicked off because they're over the income limits, and so it's from what I've experienced, it's not direct abuse, it's just lack of knowledge, and you know it's not direct abuse. I'm sure there is plenty of direct abuse there, but is it from the individuals that need the services more so than staffing? I don't know.
Yeah, and I echo that. The people I work with need this to live.
Right.
We've come up with creative ways to follow the law and follow the regulations with impairment related work expenses, things like that keep your wages, that can lower those countable wages. But then we run into, you have to keep track of 800 receipts every month, invoices every month, submit them every month, so that Medicaid can see that you are actually poor and spending all this money out of your pocket. Which that just adds more staff time, more processing time.
Mhm.
It just seems like we're running in a circle, in a hamster wheel,
Yeah,
and we're not making any progress.
Yeah, the truth of the matter is that a lot of the fraud, end quote, waste and abuse really comes from accidental payments for claims that shouldn't have been covered, right? So that's not necessarily on individuals. That's on like the mechanisms that are supposed to be in place as guardrails so that these things don't happen. And as far as oversight is concerned, the GAO, or Government Accountability Office, they have made suggestions to Congress that can save, one thing they talked about was automatically stop payments of certain improper and non-payable claims. And those improvements generated estimated $2 billion in savings over a 5-year period. So it's there, you know what I mean? But, the powers that be need to speak more to that. But in closing, I think, and, John, you follow up, but I think the crux of why Medicaid and other social safety nets, they need to be preserved, is wrapped up in a statement that somebody at the rally had said. The individual said, "I'll be on Social Security soon, and we're all one accident, a trip, and fall away from being on Medicaid." And it's, I think, that realization that everyone is heading in that direction one way or the other, and you don't know what you're going to depend on, but you just need to know that there's something in place that you can depend on, and not to box it in as though, oh, it's only for those disabled folks over there. Oh, it's only for those poor people, end quote. No, because as I explained to my son the other day, we were just talking about SNAP. And as we were having that discussion, I told him, I said, you know how much we pay for groceries? And, do you make this amount of money? It's just like, no. I said, chances are at 18, you won't make that money either. So guess what you'll need to depend on? He's like, programs like these. I said, exactly. And so if we can kind of teach that early on to folks, I think we'll be headed in a better direction, and getting our politicians to recognize that, be more humane when you're making these budget cuts and stuff.
I was at the hospital this morning. My my wife had to go into the ER, and I overheard this couple that was right next to me, and the social worker came in and she said, your wife's going to need 24-hour support, and your insurance doesn't cover it. And the husband says, I have excellent insurance. I work for the state. And she said, yes, that's fine. You can get short-term support for that, but you're not going to get 24-hour care for that. So here's your options, and make it quick. Either she's going to a nursing home or she's going home, and you're going to be paying $40 an hour for round-the-clock care. Those are that's how quickly it changes. And whether you're going to deplete your savings until you can afford Medicaid.
And that is why we're doing this, right? Is like people do not understand until shit hits the fan. Like you have no reason to look into the details of what covers what, whoever in private insurance shopping is like, oh, does this cover 24-hour caregiving if I become disabled? No, you're not thinking about that. It's the last thing on your mind. Something Connecticut Senator, U.S. Senator Chris Murphy said at the rally that I thought was really powerful is he said Medicaid is that program that says something about who we are as a civilization, that if someone is in need, if someone is disabled, if someone has an illness that has changed their life, we wrap our arms around them, not just as a neighborhood, but as a nation. Like it's an insurance program that covers the most. It should cover more, right? But the fact that if we're sitting here and going, oh no, it's the fault of the illegal immigrants. That's why we don't have enough funding for Medicaid, or it's the fault of those able-bodied people who are on Medicaid. That's why the disabled aren't getting enough wheelchairs. It's this pitting one vulnerable group against another. When you zoom out and you understand, or you ask what is the need for any kind of potential federal cut of $880 billion? It's to fund a tax cut for billionaires. Like, this is insane. And it's real. And it's insane. I don't know what else to say about it, but
Literally,
really,
we're left speechless about this entire ordeal.
Oh, and the fraud thing, talking about fraud, if you're cutting staffing, you're cutting funding, how are you going to be addressing fraud? Like, who is going to be looking into that? How is it not going to be just some unknowing person going through and checking off and listing as fraud people who, as you say, like, they're non-intentional overpayments, or they're non-intentional mistakes, because the system is so confusing, and, by the way, designed to be confusing, because that's one of the mechanisms by which states have limited their enrollee numbers intentionally, by making it a difficult system to navigate, to keep the numbers of beneficiaries down. So I don't know. It's insane. That's all I know.
Very true. But listen, thank you, Joe and Heather, for participating in our More Than Walking video podcast discussion. This was healthy, and we hope to continue it as long as need be.
Everyone, stay tuned in and sign up for the More Than Walking newsletter at morethanwalking.com to learn about the topic we will cover next and how you can participate. Also, like, comment, and subscribe to our More Than Walking YouTube channel to watch each podcast, and we'll be dropping new episodes every Monday or Tuesday. Follow us wherever you listen to podcasts. Just search for More Than Walking or Super Adaptables.
Until then, remain encouraged, stay hopeful, and above all else,
keep adapting.